All right, since we have some introductions to go, I may actually start us a shade early because I am the least important person talking today. But I just want to announce that this is the final grand rounds of the academic year and that we will restart after the Labor Day break on September the 12th. If anybody has topics they're really interested in hearing about, please drop me an email. Would love suggestions and to know what's been of interest to this group. If anybody has any feedback, again, I'm pretty easy to find in the system. Please drop me an email. So this is a very special grand round. And so I am actually very excited to turn it over to Dr. Shubh Agrawal, who is going to set the stage for us. Shubh?
Yes. Can everybody hear me? Okay. So I am honored to introduce the Karen Law Resident Selected Distinguished Speaker Series. Our inaugural speaker is Dr. Karen Law. Dr. Karen Law served as our program director at the J. Willis Hurst Emory Internal Medicine Residency Program from 2016 to 2022. Over her time as program director, Dr. Law implemented innovative programs for recruitment, diversity, education, scholarship, and wellness. To name a few, she ensured Emory was one of 3 residency programs across the country to secure NIH STAR funding. She developed partnerships across institutions, including our current partnership with Georgia Tech. She transformed our curriculum to an X+Y schedule, which was a big win for our residents. She also developed single-handedly and with collaboration, I guess, a holistic review process for resident recruitment before anyone had even used the term holistic review. She faced the challenge of COVID-19 head-on, centering our experience as residents and ensuring we were safe through incredibly uncertain times, including making sure we got vaccines. Her forward-thinking and collaborative leadership also allowed the residency program to center the core value of diversity, equity, and inclusion. She developed a parental leave policy that has since been adopted by the American Board of Internal Medicine. She also worked with our residents of the Churchwell Diversity and Inclusion Collective to develop health justice standards, and she works with the Department of Medicine to have an innovative visiting clerkship. Despite this impressive list of achievements, if you ask the residents who have trained with her what they think of Dr. Law, they think of her individualized support and personal advocacy. During her career, she centered the resident voice and the resident perspective, and it is in her honor that we introduce this series. In the future, one grand round speaker every year will be selected with the residents as the Karen Law Resident Selected Distinguished Speaker. And I will pass it over to Dr. Eric Caliendo to introduce our speaker, Dr. Karen Law.
Thanks, Shubh. Can you all hear me? Awesome. So I'm Eric. I'm a PGY2 in the program, and don't worry, I won't be taking up too much time from Dr. Law, a person who doesn't need any introduction. But Shubh asked me to tell you all why I, among others, nominated Dr. Law for the first lecture in the eponymous series. Put simply, she deserves it. She deserves a spotlight from the residents after all the time we spent at the center of her world. For 6 years, Dr. Law worked tirelessly to modernize the IM residency experience at Emory and foster strong connections between the residents. As much as someone about to turn 30 wishes, life is not put on hold for residency, but she reminded all of us that we were still real people. Her dedication to us as individuals was unmatched. A very quick story to illustrate. During one noon conference, Dr. Law saw Aaron Shepard, an intern at the time, in the audience. Having already sent him an email wishing him a happy birthday earlier that morning, she wanted to make sure that she was not the only one in the program to do so. She saw me sitting next to him and texted, "Hi, Eric, FYI, it's Aaron's B-Day, smile emoji." Who does that? People who care do that. Now, I think most of you have attended a talk by Dr. Law. She's a great speaker. During my time in the residency, though, the topics were usually focused on orientation and logistics. I've heard rousing speeches about freedom pay, aggregation, and the square footage of call rooms. But it's time for her to give grand rounds on a topic of her own choosing. In addition to a whole lot of thanks for all that she has done for us, Dr. Law deserves the stage to discuss what she's truly passionate about. And that's why I'm excited to introduce her to you all today. On top of all the great accomplishments that Shub itemized before, she is also a published author on a range of topics, including medical education, her specialty in rheumatology, as well as gender equity in medicine, specifically in medical training, which she will be speaking to us about today. So take it away, Dr. Law.
Oh my gosh, you guys. So no, this is the first time in my recollection that we have had the Grand Round speaker start with teary eyes. But thank you, Eric. Thank you, Shub. Thank you, Wendy. Thank you to all the residents. It is an honor to be here speaking with you on this side of the slide deck today. And I hope that you enjoy our talk and our time together. Okay, let me sort of gather my thoughts a little bit more since that was lovely and emotional, but let's get started. And Shub, Eric, can you guys give me a thumbs up? Am I showing the right screen? Okay, great. Okay. That was so lovely. Thank you, guys. So today, the talk that I prepared for us is titled Glass Walls, Inroads, and Off-Ramps. I hopefully with this talk will be prompting some interesting introspection and discussions on invisible barriers to gender equity in medicine and hopefully some pathways forward. So before we get started, you heard from those wonderful introductions, kind of how we got here, just a little bit more context, and perhaps you can have a laugh at my expense. So yes, I had the absolute privilege of serving as the IM residency program director since 2016. And those were some of the most intensely rewarding and challenging years of my professional life. And because we have excellent residents, there were wonderful people with wonderful ideas asking about how best to commemorate my tenure. And because I am who I am, I wanted to make sure that whatever that effort invested was both low stress for the residents and the chiefs, but also had sort of like all the elements of a great resident initiative, at least according to K-Law. And so to me, those things include that it's resident driven, that it's good for the residents, air quotes, because not everything that residents ask for is actually good for residents. But for me, the things that are good for residents: amplify resident voices, address a resident goal, support resident personal and professional development. And then because I am so pragmatic, you guys know this, it's got to have excellent impact to cost ratio. It's got to be sustainable. It's got to be practical. And so as we started brainstorming some of this stuff and keeping the elements of a great initiative in mind, I thought, oh yeah, a resident invited grand round speaker. They added the distinguished in there as well. Sounds like a great initiative. And naively, I envisioned, sitting back and enjoying a most thought-provoking and high-profile resident invited distinguished grand rounds talk, maybe with one of these illustrious people, Tony Fauci, very timely, Stacey Abrams, Andre Churchwell, our residency program's first Black chief resident and current chief diversity officer at Vanderbilt, would be great. Or Reshma Jagsi, she is our new radiation oncology department chair. She's also a pivotal voice in compensation parity for women physicians nationally. And so we went with it. And when the chief residents came and sheepishly notified me that I was, in fact, the resident's choice for the first Karen Law resident invited distinguished speaker, I was all the things. So I was flattered, I was humbled, but also extremely amused that maybe Eric and others didn't really understand the task. So this year you have me, but next year, residents, I encourage you all to aim higher, and I look forward to who we invite next. So with that context in mind, let's get started. This is what I hope to talk to you all about today. And our objectives today are ambitious. So hopefully together we can appreciate the progress of women and gender equity in medicine. We can examine how policy and policy workarounds can perpetuate disparity and can really perpetuate disparity in all of its domains, although today we're going to be talking specifically about gender disparity. And then reflect on past and present physician parenthood culture and what those implications are for the future physician workforce. And honestly, by bringing you along this journey with me, I hope to share the stories of trainees I've been fortunate enough to walk alongside, and share also some of the behind the scenes foundational work that program directors do to support their trainees, which is sometimes underestimated, sometimes. I also hope to demonstrate by telling the story, maybe a roadmap or a recipe for how we can move the needle and make definitive changes in these spaces. Okay, so let's start with a story. It is 2015, and I receive an email from a medical student, and it says something like, "Hey, Dr. Law, you don't know me, but can I meet with you and ask for some advice?" And so, of course, I say yes. And when we meet, this woman medical student describes a pretty gut-wrenching personal and professional dilemma. She says she and her partner have been married for 5 years, and they are really eager to begin family planning. And she proceeds to recount the following conversation with her med school advisor, whom she truly believes cares for her. And so she says to her advisor, "My partner and I would like to talk about family planning during medical school." And this advisor says, "Sure, you can probably do that, but not before step 1, because you really need to focus then. And then also, like, not during clerkships. That would just be unnecessarily tough. 4th year could be good. Some people have babies during 4th year, but be careful about being pregnant during residency interviews, because that could be perceived as though you're not really ready to jump in with both feet. And then also, of course, juggling an infant during intern year is really tough. Like, I would avoid that at all costs. And also just be aware of that same timeline if you're planning on further training after residency." So the conclusion of that meeting was, the faculty advisor said, "It's not really a no, but. And so much weight of the world and this med student's aspirations was stuffed into the word "but." And the context of this conversation is really important. So this is AAMC data, and they have been tracking med school graduates by gender for decades. And you can see here that in the 1980s, the historical graduation rate of women from medical school is at its lowest point. But I'm having this conversation with a med student in 2015. And so that's right in the middle of a plateau of parity between women and men's med school graduation and matriculation rates. And this trend will likely continue. So in the 2022 application cycle, women made up 57% of applicants and 54% of total enrollment in US medical schools. And it is the 4th year in a row that women made up the majority of all of these groups. And that's a great thing, a really, really good thing. That is what we've been working for and what we have been celebrating, right? I think so. But also this era of gender parity in medical school matriculation is landing at a time of peak reproductive years. So I'll remind you, the average age of students entering medical school is 24. And, we're all healthcare professionals here. So I'm stating the obvious when I tell you that most med school, residency, and fellowship training occur during active family planning years, peak reproductive years. This is the window that we remind our patients to be aware of when they're family planning. So this is all stating the obvious, right? Okay, so with that student's dilemma in mind, let's review some historical vocabulary. So the glass ceiling is a phrase that was first coined by Marilyn Loden, who was an HR executive in 1978 during a panel discussion where she was invited to discuss discuss women's aspirations in the workplace. And on reflecting on that panel, she said, "I noted how the female panelists focused on the deficiencies in women's socialization, the self-deprecating ways in which women behaved, and the poor self-image that many women allegedly carried." So basically, she watched women on these panels blame themselves for their failure to ascend the promotional ladder. At this meeting, she was the only one who reflected out loud about how often she was told by her leadership to smile more, how she would receive daily comments about her appearance, and how in hiring conversations, she often observed people discussing that the advancement of women was, quote, degrading the importance of these positions. So basically, she was the first to point out that there were serious external factors playing into women's challenges with promotion. And so she said, true, women did seem unable to climb the career ladder beyond the lowest rung of middle management. But I argued that the invisible glass ceiling, the barriers to advancement that were cultural, not personal, was doing the bulk of the damage to women's career aspirations and opportunities. And so from there, a movement defining term was born that really encapsulated the systemic barriers women and minorities faced from moving up in the workplace. And by defining the barrier as cultural and not personal, she called out an invisible but all too familiar structural barrier that we refer to today as systemic bias. Okay, so with a glass ceiling framework in mind, what are glass walls? Well, if glass ceilings describe the systemic bias in workplaces that prevent minority groups from moving up, glass walls represent the ground level barriers that we need to address. And, the business literature describes them as the subtle ways in which women and other marginalized groups may be excluded from certain jobs or roles within an organization, or barriers that prevent a woman or a minority group from moving to a position that has a promotional ladder or prevents them from performing effectively in their roles. So glass walls may be subtle, but their effect is very, very real. And you'll see why as we keep going. So some have even proposed naming some of these glass walls because they're so invisible and yet so pervasive. So if you'll humor me one last slide on this analogy, in the business and sociology vernacular, we now have one additional metaphor, the maternal wall. And this is what we'll focus on today. So first coined by Joan Williams in a Harvard Business Review essay in 2014, she writes, the maternal wall not only comes out of nowhere, but it impedes our ability to get anywhere near the glass ceiling. She goes on in that essay to note that women then find themselves trying to defer parenthood, searching for an elusive, appropriate time, and make up for any perceived deficiencies after parenthood, essentially bending over backwards to ensure that no coworker could accuse her of performing differently postpartum. And I'm sure that for any parents in the audience, this experience is quite familiar. And I would wager that this burden is painfully familiar for our women in the audience. So she goes on to say, so then we, the animation didn't work. But so women who have been very successful suddenly find their proficiency questioned once they become pregnant or take maternity leave. Okay, to summarize, glass ceilings are invisible barriers that prevent minority groups from moving up. Glass walls are invisible barriers that prevent minority groups from performing effectively in their current roles. And the maternal wall is a pervasive, invisible barrier that indirectly limits family planning, career opportunities, and the general experience of women in the workforce. So to revisit this particular student's story, she reflected at the end of our first meeting, I knew a career in medicine would require sacrifice, but no one told me it would require sacrificing childbearing completely. No one told me. Glass wall, right? Okay, so I carried that 2015 conversation with me, and I was convinced that we had to find a better way for that student, and every student like her, and all the others who might similarly be celebrated for bringing much needed diversity in medicine, only to get stuck behind these glass walls. So looking for pathways forward that could help us make definitive change. And in 2016, an opportunity came along, a door, if you will, from the wonderful Gina Lundberg, our passionate clinical director of the Emory Women's Heart Center. So she wrote, Dr. Law, here I am. I'm Gina Lundberg. I'm an Emory cardiologist. I have an interest in heart disease in women. I also have an interest in women going into cardiology, and I work to mentor and encourage women from high school all the way up to our female fellows. And those of you who know Dr. Lundberg know that she lives this life. She went on to say, I want to see women continue to go into medicine, and I want more women to consider cardiology. I love my career, and I know that women physicians can balance motherhood and career. And Dr. Lundberg proposed that we participate in this AMA-sponsored study on childbearing among physicians in training. And the highlighted background identifies the scope of the issue quite well. This study that they were sponsoring would be the first study of maternity leave during residency in 20 years. And the last time a multi-center study was done on this topic, it revealed that 30% of birthing parents took less than 4 weeks of postpartum leave, in complete conflict with ACOG recommendations for healthy maternity leave duration for all birthing parents, essentially confirming what I think we already know in the pit of our stomachs, which is that physician culture doesn't recommend for ourselves the same things that we recommend for our patients. So more on that later. So we jumped in as one of 5 other participating sites in the study. We had 8 specialties represented from Emory, and you can see them there. And then alongside UW, USF, Michigan, UCSD, and the University of Utah, the study included 78 different residency programs representing 25 unique specialties. So it was a lot of work for us, but I think we all were extremely passionate about the work and we felt that it was very worthwhile. And I will also note it was probably one of the most organized, transparent, and equitable approaches to authorship of a multi-center study that I'd ever been a part of. And that was something that we were really proud of as well. And this study was landing at a time that others were really shifting their awareness towards related glass walls, gender differences, inequity related to physicians' domestic responsibilities, family and childbearing leave policies. That was all in the mix during that time. 2017 was also a landmark year in which the number of female students in medical school exceeded male student matriculation for the first time. And so we were really proud to publish this work at this moment of inquiry and discussion. And here's what we found. So first, we found that maternity leave length varied considerably across the 6 participating institutions. Paid leave was generally limited to 6 weeks or less for most trainees, but the same institution faculty policies were much more generous. And the desire to avoid extension of residency training was the most commonly reported determinant of maternity leave duration. So, in thinking about those things, the second bullet point really points to the tension that's inherent between peak childbearing years, as we discussed, and time and experience limited training, which by its very nature is med school, residency, fellowship, et cetera. And then also maybe like a little sprinkling in of the legacy of hierarchical medicine that continues to exist in the way we practice. The third bullet point really, and the figure, which clearly demonstrates how strong the desire was not to extend residency training further, really points to the power of, for us in internal medicine, the American Board of Internal Medicine, but also for others in different specialties, the American Board of Medical Specialties, and how much power they have in influencing parental leave decisions, because ultimately they're the credentialing body that determines residency training length. So in addition to these conclusions, as with much of scientific inquiry, the data actually also led to more questions than answers. And our most surprising findings were not specifically reported in this study because the study was was structured to dichotomize maternity leave length to either greater than or less than 6 weeks. And the most representative surprising finding, I'm just going to focus on one of them for the sake of brevity, was that more than 90% of residents at the University of Utah took less than 6 weeks of birthing parent leave, despite the option of 100% paid leave for up to 12 weeks, which I personally found to be very perplexing. So our author group had a really robust discussion about this, especially for those of us like myself that were crusading for augmented paid leave for residents. So here were some real-time quotes from our email and text discussions. There was, comments about culture and already supportive environment at Utah for pregnancy during residency and family support on return to work. Okay. Some people referred to the conclusions from our original study saying it's all about training time and keep in mind the credentialing board policy, which is influencing people to return to work early because they don't want to extend training. Okay. But then we also got comments like this. Well, I was able to have my baby on research time, or we have rotations with flexibility that residents can choose specifically for return to work after maternity leave, or we have 6 weeks of lactation rotation or other similar rotation that usually pads this time away. And many of us on that text chain said, I wish we had that, right? So this helped us to see the limitations of the initial study because we had our hunches, but we couldn't fully characterize the issues with the data that we had. And therefore, we weren't yet at the point where we could propose definitive change, but we were close and we kind of knew what we had to do there. Other sort of take home from this dialogue, I also want to highlight is you can note there that there is an implicit agreement among all the participants in this conversation that postpartum leave needs a supportive culture, needs to be paid, may need to be longer than 6 weeks, and is strongly influenced by fears of extension of training. All these things that were not and are not yet a part of our culture of physician parenthood. But also our take home was much deeper than that, because sometimes solutions perpetuate the problem. And this gets at the heart of why transparent policy is so important and was a major recommendation out of our first paper, because well-intentioned parental leave workarounds like parenting rotations or having your baby on research time that are not counted as traditional maternity leave, they're great because they support extended duration of leave for trainees and they facilitate extended leave without extension of training. But they're also not great because they inadvertently normalize maternity leaves less than 6 weeks duration, because what it looks like on paper is that your trainee took less than 6 weeks. They're also not codified. So they're also at a constant risk for loss because they're not actually written anywhere that someone in the future can reference. Similarly, it really depends on who you know. So again, you saw in that conversation chain, one of the program directors said, I usually recommend that the trainee takes a 6-week lactation rotation. So it really depends on who you know and may not be available to everyone. And it, of course, does not promote supportive policy change that would change the experience for everyone, not just the ones who know the right people. So while workarounds are very well intentioned and they can help individuals navigate around glass walls, the goal really should be to remove the wall completely by addressing the problem with definitive change. Okay, so what were we going to do from here? We signed up for another round, and this time we worked to understand how childbearing decisions in residency were made as a next step. And we were really proud again to publish the results of this work in Academic Medicine in 2019. And we asked lots of questions about desiring pregnancy, timing of family planning, expectations for birth parent leave. This figure shows the self-reported determinants of delaying childbearing. And the most frequently reported factor was busy work schedule. If I could go back in time, I'd probably term that something different, but we could call it busy work schedule, followed by concerns about extension of training, access to daycare finances, and burdening colleagues. So 2 comments about that. The first is that, again, this category, busy work schedule, it elicited a lot of free text comments that were particularly illustrative. Things like, it would break my heart to go back to work after just 4 weeks of parental leave, pointing again to the challenge of how internalized short parental leaves for trainees and for physicians really are, and how workaround solutions like parenting rotations at the University of Utah don't really help with changing this perception. The second is regarding this category, the parental leave would burden my colleagues. Because as much as the community mindset is the beautiful norm in residency training programs, I wonder how many faculty in the audience who have expanded their families as faculty members would list something similar like partner call coverage in one of their top 5 reasons to delay childbearing. Again, we receive particularly telling free text comments like, the good residents take as little time as possible, essentially naming this dichotomous variable where we tell ourselves good physician equals as little leave as possible, while we tell our patients good parent equals as much leave as possible. And that's like, it's a math problem. That is an unwinnable game. So yes, this is a complicated system with glass walls limiting how at this point in 2019, greater than 50% of our rising workforce make important life decisions, and limiting how this same workforce are able to follow the standard evidence-based parental leave advice we give our own patients. So this really should prompt some introspection about our existing physician-parent culture. Okay, another comment theme that bears mentioning here that was not a loud signal, but was an important one nonetheless, is this concept of parenthood as career threat. That pregnancy and parenthood were perceived as a disadvantage for future opportunities for both fellowship and for faculty appointments. Reminiscent of the impression our original student in the first few slides was given when she was considering family planning. So again, referencing this invisible barrier of the maternal wall. Okay, so that's what we found, and we were all discussing again with our study partners, where do we go from here? And as you recall, this journey started in 2015. I shared one trainee story, but honestly, at this point, there were dozens, students and residents coming to me, basically asking if medical training and physician culture by extension makes room for family planning at all. And if so, what does that look like? And is it healthy or survivable? And so here I found myself in the thick of it with our study partners. We are working through our data. We're trying to characterize our trainees' experiences with an eye towards definitive change. So this is the 2018 Academic Internal Medicine Week. This is, for those of you who are not familiar, where we have our annual chief residence meeting, our program directors in internal medicine meeting. Basically, if IM residency education means something to you, you're there. And so we're all there, including a bunch of our study partners. And we are all talking about our papers and the associated workshops and all of the early release data and all of that buzz. And we're all trying to learn from each other how best to support parental leave and promote definitive change. And the take home from all of these discussions, we really fell into two main buckets. The first was that many programs didn't have any formal parental leave policy. 2018, no formal parental leave policy, bad. Programs that have policies have significant own institution variability. So many program directors would say, yeah, we have a policy, but like it is applied very differently between residency programs or between different, hospital locations. And so also bad. And then many people, again, this is the program directors meeting. So these are people in residency leadership. Many people didn't even really understand their own institution policy. Second bucket is that at that point, numerous papers on parental leave had prompted statements from national medical specialty societies who were calling for flexible solutions for board eligibility and duration of training, but there was no clear or consistent message from any of the credentialing bodies. And for the internal medicine credentialing body, the ABIM, there was no consensus among the program directors at the internal medicine program director meeting on if the ABIM's existing policy actually would support a 6-week parental leave without extension and training. Like half of the program directors said that you could, and half the program directors said you couldn't. So we couldn't even agree amongst ourselves. So that brought up the next set of questions for our study group, which seemed pretty obvious at the time. When there are existing leave policies, do we understand them? And so let's take a look at them. So here is the ABIM leave of absence policy from 2018. It says up to 1 month per academic year is permitted for time away from training, and training must be extended for any time or any absences exceeding 1 month. Okay. So let's look at this a little bit more closely. Again, up to 1 month per academic year is permitted for time away from training. They go on to say, if more than 1 month is taken, the deficits in required training policies activated, it's this other thing, and that permits up to 1 additional month for leave. But I mean, asking this group, is this clear? Could a resident take 8 weeks of maternity leave in a single year of training, and would that require extended training? I can assure you that in 2018, I had read that policy about 9 million times, and I still didn't understand it. And again, at the meeting, half the program directors said yes, and half the program directors said no. Okay, but also now, a big what if. What if the ABIM defines 1 month to mean 5 weeks or 35 days? Don't try to make sense of it, but with just what if. And this was actually, in fact, their definition. The language that they used was totally unclear, and it had not been updated in decades. And this leave policy was so misunderstood by IMPDs that it resulted in many examples of unnecessary extensions of training. Okay. So we're reviewing all of this together in real time at the meeting. And one of the critical issues, which I highlighted already, is that the ABIM's definition of 1 month is 5 weeks, whereas most PDs interpreted 1 month to mean 4 weeks because, normal calendar math. And none of this made any sense. So what did we do? All of us decided we're just going to go find the ABIM representative and have a face-to-face discussion. So, anytime you go to a meeting, they have the exhibition booths where they keep all the coffee stations and the snacks, and you have exhibitors, pharma, and ABIM always has a booth there. So this poor ABIM representative at the meeting was descended upon by me and our study partners. And he looked at us like we had 3 heads. He was like, yes, 1 month equals 5 weeks equals 35 days. And he said, surely PDs know what we mean. He went on to say that the use of the term 1 month rather than 5 weeks was meant to give PDs maximum flexibility. But as our discussion went on, we also determined that this policy was drafted many, many years ago, before women were as prevalent in the physician workforce and before maternity leave was a regular occurrence in residency training. So glass walls, right? And based on that very confusing conversation with this ABIM representative, our group of study authors all blurted out as we walked away, we need to get into the PD survey, because there is an annual survey of all internal medicine program directors that goes out through this organization every year, and it is updated to ask about topics of interest. So we cover everything from like program director academic rank and salary to virtual interviews, resident clinic templates, like it's all the hot topics, right? And our study group knew that we needed data to convince the ABIM that a problem that they did not see, an invisible barrier that they couldn't see, we needed data to convince them that it actually existed. And so we did. So in 2019, we received the following email. Congratulations, your topic, parental leave policies and internal medicine residency programs, was accepted for the fall APDIM annual survey. And this work was really important because we knew that we had to prove our point with data, since we had learned at this point that it's otherwise really hard to convince individuals or organizations that a problem that they cannot see really exists. So we structured this in a very deliberate way. And what we did was we presented a series of scenarios in the PD survey and asked program directors to determine, based on the scenario and existing ABIM policy, if extensions in training were needed. So you can see here, this is an example of a scenario. This is a resident, they're going to take maternity leave, blah, blah, blah. But what matters here is this center column, the proportion of program directors who answered that scenario correctly. So for this scenario A, 6.5% of internal medicine residency program directors answered that scenario correctly in terms of whether or not that resident needed to extend training time. So that was scenario A. Scenario B, only 32% of program directors answered that scenario correctly. Scenario C, 9.7% of program directors answered that scenario correctly. So we presented 8 scenarios in total, and the number of program directors who answered correctly pretty much adhered to this extremely concerning pattern. Conclusion, PDs really did not know what they meant, okay? And this face is really the face of every program director who has had to tell their trainee to defer fellowship or pregnancy or extend time based on a very unclear policy. This is a really big deal. This is a really big deal. Because the full impact of this unclear policy language may never be known. Many trainees have probably put off their career plans, especially in fields that are lacking in gender equity. I know we've all had anxious conversations with pregnant residents about how their fellowship interviews may be received, and I'm sad about it, but it's true. Similarly, for trainees pursuing hospital medicine and primary care, extensions in training may mean that job searches are not optimally timed with recruitment for July start dates. And conversely, trainees may have accepted shortened parental leave, forfeited vacation to avoid training extensions, and that has significant implications for parent and child well-being, postpartum depression, breastfeeding, and all the outcomes that we as physicians are highly attuned to for our patients, but maybe not necessarily as attuned to for ourselves. So, we should be horrified by this. Every single one of us knows how hard it is to get through medical training. And we should be horrified at the impact that this may have had on individual career trajectories and the off-ramps that these individuals may have chosen as a result. So this brings me back to the title of this talk, because in spite of all the inroads women in the physician workforce have made, there's still so many glass walls and inadvertent off-ramps, the family planning and maternity leave one being a huge one. And just to underscore the connections here, I put some of the earlier quotes here as a refresher. Because the thing about invisible barriers and glass walls is that they have impact beyond the disappointment that the individual experience, which was palpable in my initial student example. The impact that they have is just disappointment, yes, but they also impact the choices people have, and they influence huge, major life decisions. And for me, this is what what this illustrates is, yes, the importance of inroads, absolutely, but also understanding and addressing unintentional off-ramps. We worked so hard to increase numbers of women in the physician workforce. We celebrated when that happened, but then how did the training structure that we have in place, all of it, all the stuff about the good residents take as little time as possible, the stuff about you can have a baby, but not at any of these time points, and the surely program directors knew what we meant language of policy. Like, how did all of those reinforce glass walls for women physicians? And as much as we celebrated their inroads, how many found themselves choosing off-ramps? It's a really big deal. Okay. So don't despair. That was like 2 very sad slides for me to write, but don't despair. Data prompts definitive change. It does, it can. So in 2019, based on the results of our survey and the abysmal performance of program directors on the quizzes, the ABIM collaborated with internal medicine program directors to update their language. And so they updated their language to really move from surely people know what we mean to a genuine specific policy, or genuine changes for a specific policy. So first of all, they finally spelled out 5 weeks instead of a vague month. And they were also very clear with their policy that the time for leave of absence should be cumulative over the duration of training, so you can have it be additive, and that it should not entirely exhaust vacation. So data prompts definitive change. And I was actually extremely, extremely proud of how quickly this changed, because again, the survey went out to program directors in the spring of 2019. And in that same calendar year, we had an update to the language. And the American Board of Medical Specialties, which governs internal medicine related subspecialties and fellowships, followed suit in 2021. Took them a little bit longer because some fellowships are not 3 years in duration. And so it does sort of impact how they think about required rotations and stuff like that. But they did specify minimum of 6 weeks of time away from training for purposes of parental caregiver and medical leave, at least once during training. Okay. So here is a very telling comment from a program director. I almost told my senior resident not to apply for fellowship because her maternity leave would require extended training. But when the ABIM policy clarification was released, I realized I was wrong. And that's why policy matters, and why policy can have lasting impact on equity in the physician workforce. It really matters. Okay, things are better, but there's still work to be done, right? This stuff is messy. Our work has resulted in policy that affirms that sometimes pregnancy and family planning happen, sometimes life happens, and you got to take time. But we are not there yet. Things are still very messy, and there's still a lot of work to be done. And that is really the thing about invisible barriers like glass walls. They are everywhere, and you only see them when you yourself bumps into them, or when you listen to someone who tells you they bumped into one of them. Okay, so rounding the corner, I will leave you with one last story. So this is my son, Eli, who was born in 2015. He is the cutest baby there ever was. No one can tell me different. But he is and was also the hungriest. This is my office for my clinical practice. It is a familiar place, Emory Clinic, Building A. So I came back to work after maternity leave, as many lactating moms do. I had a giant bag of pumping supplies. And in addition to sleep deprivation, I had a very unique stress that only other pumping moms can understand, because you're managing workload. You're also trying to manage sort of like the pressure you place on yourself to show that you can really be 100% back. You had a new baby that's like waking up 2 to 3 times a night, if you're lucky, and the logistics of pumping. Like, it's a lot. It's just a lot. Okay. So I assumed I could use my office. It was steps away from clinic, seemed like a no-brainer. It was my office after all. But there was a catch, and that was in 2015, this was a newly renovated section of the Emory Clinic. And it was one that people were very, very proud of. It was bright, it was shiny, it was thoughtfully planned, and every office door had a window. Okay, I didn't think that was that big of a deal. I put up a piece of exam room paper for privacy while I pumped. The next day I returned with all my pumping supplies and like 4 hours of sleep, ready to see 10 to 13 patients in a half day. Next day I returned and my privacy paper was removed. So I put it up again. And the next day I returned and it was removed again. I thought, weird, it's my office. Then I got a visit from one of the clinic administrators who told me the architects of this renovation feel that the transparency of the doors is integral to the success of the redesign. Isn't there a lactation room that you could use across the street in the School of Medicine building? So again, I will remind you, there is nothing like the stress of a sleep-deprived pumping mom on return to work. But now somehow in this conversation, I am sort of being told that my parenthood is also responsible for compromising the aesthetics of the redesign. I will also add that in preparing this talk, and I can't believe that it was only 8 years ago, 8 years ago, the only dedicated lactation facility on Clifton Road was a single room in the School of Medicine building, which is a building for students. Again, women have been 50% of the rising workforce in rising physician workforce since the early 2000s. But here we are, it's 2015, and there's one lactation facility. And I'm being told that in the middle of seeing 12 patients per half day, I should find the time to pack up all my stuff, run across the street to the one lactation facility that is available and is supposed to be for students, and use that because covering the door to my office is compromising the success of the redesign. So, okay, again, it's 2015. In this lactation conversation at this point, which you can tell I am still really fired up about, I was established enough as a faculty member to push back both in the moment and then also through the subsequent flurry of emails that, frankly, was a conversation that should never have happened. But this was also the same year that original student came to me asking me, is physician life a life that she had been invited to join? Did it mean sacrificing all of these other pieces of herself that she didn't know would be a part of the deal? And I know that if I had been a student, a resident, a fellow, or even a junior faculty member, I don't know that I would have felt that I had the footing to push back. And I imagined how that felt. So needless to say, I figured out, we came to a consensus on whether or not I was able to pump in my office. I will also say that if you walk through the Clinic A building redesign now, anyone who has a glass door to their office has also posted things for privacy so that they can work in their office privately. But that is a different conversation for a different day. The take-home point I want to leave you with is really about what physician parenthood culture is and what we do to perpetuate that, because these are hard topics, but they are really important ones for us to address. And as we think about how we as physicians support each other through family planning, parental leave, return to work, lactation, should we not expect for ourselves as physicians the same level of care that we recommend for our patients, an evidence-based level of care? And sort of coming at it from a different angle, like, why have we normalized this type of physician parenthood culture? Is it like superhero mentality? Is it the good physicians take as little time as possible mentality? Is it so deeply ingrained in us that we don't even question it? I don't know, but I think these are hard topics and important ones for us to address, because really it does start small with little microaggressions, exactly like this lactation conversation. Okay, so this is where I'll end. And if you have stayed with me through this talk, hopefully I have convinced you that we have made considerable progress with gender equity in medicine, but that glass walls and a challenging culture of physician parenthood persist. And if you have been kind of listening along, but you're also thinking to yourself like, okay, this is important, and I see how Karen is very passionate about this, but also maybe you're mid-career faculty, you walked uphill both ways to the hospital and you turned out okay, and this feels like a lot of effort focused on a narrow demographic. Or maybe you're a man and you feel that this is not relevant, or maybe you identify as a woman, but you're not interested in pregnancy, so you, again, don't feel like this applies to you. I will tell you that our study group felt that regardless of who you are, this discussion applies to you. Because as we thought about physician culture as a whole, we were very proud to make these comments in the discussion of one of our papers, which felt kind of like they were overreaching, but we put it in there anyway, because we wanted to put these words out into the universe about why this matters, even though the title of the paper only mentions women residents. And what we said was, implementing policies that address resident and program concerns is a key approach to improving the culture of physician parenthood. We recommend addressing parenthood as a whole rather than focusing only on maternity leave. This perspective has the potential to normalize resident parenthood, making it less of a gender-specific issue. It would also support the full engagement in parenthood of residents of all genders, rather than primarily emphasizing the role of the childbearing parent, which was really important to us, that we wanted to talk about the participation in parenthood of all genders. And I promise you, in this month of Pride, we were also talking about families of all flavors, okay? And what we concluded with was, by identifying obstacles, the goal of this study is to create a more sustainable path for residents to pursue childbearing if they choose, signaling not only the inclusion of parenthood in training, but also an appreciation for the personal lives, growth, and well-being of all residents. If they choose, an appreciation for the personal lives, growth, and well-being of all residents. Because the culture that we create for residents becomes the culture that we perpetuate as physicians. And so there is a lot at stake here, and that is why that matters. Okay, my last slide, which I'm a little teary just looking at. I am so proud to have walked alongside so many residents who have been courageous enough and excited enough to expand their families during training with us. If you don't see your favorite baby, please forgive me. It's a lot of faces to fit on one slide, but I am so proud to have walked alongside all of these residents in all of their journeys, but especially these residents who have navigated parenting during residency. Thank you.
Thank you, Dr. Law. That was extraordinary. And the comments in the chat are worth looking at when you get a minute. I have a question for you from Dr. Higgins, who disclosed that she might be at the beach, so I'm going to ask it for her. As our profession approaches 50-50 women and men, do you think the culture is improving to accept these asks, or are they being considered before designing the building with the glass doors that contribute to the culture?
You know, I think you'll find, yes, we're making progress, and yes, these discussions are making progress, but then I think you'll also find that because these are glass walls and they're part of the wallpaper and part of the culture that we accept, that you'll still have, you know, I can remember a conversation with a lactating mom returning to work from maternity leave, and the ICU team that she was joining, and the conversation was, what should we do? It was a well-intentioned conversation that was meant to be supportive. But the question to me was, what should we do? Because we usually have didactics at 10 and she goes to pump at 10. What should we do? And, you know, I mean, I think, you know, when we take ourselves out of like the work environment and the wallpaper that we accept as normal, I think all of us looking at each other today are like, well, just move the didactic time, right? Like, that's okay. But, you know, it really was such a well-intentioned question. Like we want her to have a full experience. We don't want her to feel pressured about pumping, but we have didactics at 10. And really, like, that was the solution is is it possible for us to have didactics happen at a different time? Oh yeah, you know, we can probably do it after lunch. So I think there were many women on that conversation, I guess I would just add that. And so I think while there is greater awareness and more dialogue happening, you'll still bump into things exactly like that, where maybe we just need to make a couple tweaks that honestly don't change very much of the day-to-day experience, but make it a little bit more inviting for someone who just needs a little accommodation.
I have a question. You alluded to this at the end, but the residency is a microcosm of all of physician culture. And GME and other, organizations can change the structure of residency or can make policy. But how many of my friends and colleagues in medicine, but also in other specialties, especially the men who don't feel even that they can go say, I'm leaving to go see my child's midday play at the elementary school. How do we move forward on that, where there are so many individual cultures dictated by so many individual units within an academic medical center?
It's a big sigh, and I don't know. But I do think, there was a lot more detail to that discussion in the slide that I shared, where the study partners we were all sort of trying to figure out why resident experiences at the University of Utah are different. And so I guess that's a great example of what a different supportive culture could look like. And I think the reason, I know, having spoken to their leadership, that their microcosm of supportiveness looks different and includes up to 12 weeks of paid leave for trainees, for parental leave, because they have such a large Mormon community where childbearing early is the norm. And what that looks like is, so that has created a culture and policies that support that culture that are just so different from, honestly, what our experience is on this campus and what our typical sort of wallpaper expectations are on this campus. But because of that, all of those types of family leave and personal and professional leave are accounted for. And because they have a culture where there's a lot of moving in and out of training, as more people move in and out of training, more people cover for each other. And it is also normalized that extensions of training, while it does feel horrifying in the moment as an individual resident to think about, is survivable, and that your career will not suffer as a result. And all of those examples have sort of been run through on that campus because they started with a different type of supportive family culture.
We're at the top of the hour. We also have a ton of questions. Do you have extra minutes?
I have extra minutes. I'm also understanding if people have to drop off.
So I'm going to give permission to people to drop off our very first Karen Law Distinguished Resident Selected Lecture Series. And if you will, and for an extraordinary talk, and thank you so much. I think our residents did aim at the highest level. I am going to get to some of these other questions, but again, nobody feel like you'll be insulting Dr. Locke. You have permission. So we have 2 hands raised and a couple of questions in the chat. I don't know who St. Francis Emory Healthcare IM guest is, but please feel free to unmute yourself and ask your question.
Oh, hey, I'm Andrew Hearn from St. Francis, and I'm actually the parent in question. I'm expecting my daughter in September, and I was planning on taking, trying to take 6 weeks, but the understanding is that we have 35 days a year, of non-training. So if I'm also, taking 4 weeks of vacation every year, how does that still work as far as the credentialing eligibility? The question came from my program director, but I'm happy to be the one to ask it. Thank you so much.
Yeah, of course. The clause that helps you, that the ABIM added in 2019, is how they specifically added that it's up to 35 days per year of training that can be cumulative or additive over the years. So what that means in a traditional internal medicine residency training is 35 days times 3. And that is where you get to preserving vacation, because also, I think on paper, I've certainly been in conversations where people say, well, they'll add, their weeks of vacation to make parental leave. But then also, do we feel that that is healthy and survivable? to go, 11 months with no vacation while you're also pregnant? Probably not. Also, is it healthy and survivable to come back from parental leave and then just work for another 11 straight months? Probably not, right? And so I think the key to answering your question about being able to take a sort of normal society agreed upon amount of parental leave without extending training is really about the cumulative aspect that you can bank the 35 days times 3.
Perfect. Thank you so much.
Dr. Manning.
Dr. Sonu said I had no chill in the chat because I was excited, but that's true. First of all, I just want to say thank you. It was really a pleasure to get to hear you speak to us, and that was really outstanding. I have a comment and a question. The comment really comes from those of us who as junior faculty experienced a lot of what you described. I recall doing 8 straight weeks of wards at Grady to cover my clinical responsibilities on the inpatient service, and then banking all of my maternity, all of my vacation to get an additional 4 weeks, but then returning to work 2 weeks early because I felt so anxious about how many people I was burdening back at Grady. And my question is really one that I think is an elephant in the room. As we think sensitively about birthing parents and their time away, my division was supportive, but I just couldn't feel comfortable knowing that somebody else was taking on what I wasn't there to do. And so I wonder in these discussions to change policy, does the policy also include something that incorporates the wellness of the individuals who may not desire to have children or ever will have children, but who are there still as a part of the workforce, particularly as the percentage of women in training programs and in medical schools is growing?
It's a great question, and one that I think we haven't clearly answered yet. And I think, I have been a part of so many conversations where that is very, very important, because you're right. I sort of presented a historical perspective of how this conversation has evolved over the last 10 years. And we certainly are at an inflection point where the ACGME last year codified that trainees should all have access to up to 6 weeks of leave for parental leave or any personal or family medical need that they had that may arise. And, I think the momentum has really been towards demonstrating, now that we recognize that the culture has not been supportive, really bending over backwards to demonstrate that the culture wants to be supportive. And I think that that is really important and is a success, but also in that should not inappropriately penalize people who choose not to participate in family planning, right? And that and these the ways in which we distribute that effort equitably are still evolving. And I think we're building that plane while we are flying it. But it is very important for us to always keep in mind that that doesn't mean that because you are a fellow in a class of 5 fellows, and 3 of them go out on parental leave, and 2, that the remaining 2 fellows are covering all of the challenging rotations or service responsibilities, or however you want to put it. I do think as we, hopefully, as a physician culture, I talked a little bit about physician parent culture, but there's so much in there beyond that about physician culture in general, about being accepting of all of life's events and supporting each other through all of life's events. So I think as we become better about supporting all of those, perhaps the initial, perhaps the accommodations for families will become less of a single issue. And to be really concrete, what I mean by that is that, some of us may need to take time to support an aging parent, or some of us may need to take time to support a sibling through a significant medical diagnosis. Some of us may need to take time to support ourselves through a significant medical diagnosis. And then it becomes a little bit more equitable in terms of how we support everyone in sort of managing all of life's events.
All right, it's 1:07. I'm going to force you to do something you don't like to do. That's rapid fire.
Oh, gosh.
3 questions for you.
Okay.
this is an issue for students as well. Do you have any thoughts about how the progress at the GME level could be extended to the student level?
I think we got to be flexible with timelines and milestones. I mean, there has been so much conversation at an education level about creating competency-based milestone training. So not this, well, you made it to the end of third year of med school and your grades were okay, so you just keep going. I think those timelines are really we need to be able to move to that place so that people have the freedom and the opportunity to choose the timelines that work for them, both personally and professionally. But I think that well-meaning advisor to the student that I talked to in the beginning, would probably still sadly have some of the same recommendations. If you're pregnant while you're interviewing for residency, that might be perceived a certain way, and you may not want to have a baby before step one, because how can you study for this really high stakes exam? I think there is motion and slow progress towards milestone-based evaluation, and that really is probably the most important pathway forward.
In your work, there's a question about whether the responses, the differences, oh shoot, hang on, I just lost my spot. The differences in responses, did you look at men and women, males and females, childbearing, non-childbearing parents, or people of non-child or childbearing potential in the work that you did? And were their responses similar or different?
So no, the original data that we collected was primarily among women choosing childbearing. And that is not to be exclusive of men or parents in all forms, but really that to us, this seemed like the lowest hanging fruit to make an impact. And the reason for that is, again, because as physicians, we recommend for our pregnant women parental leaves that are at least 6 to 8 weeks, et cetera. And so that offered us the opportunity to sort of like pry open the door and have this conversation. I think at this point, the conversation is now at a point where, some of you may know that the Emory, that because the ACGME policy makes accommodations for 6 weeks of leave for both childbearing and non-childbearing parents, what that helps to introduce is maybe a little bit more of a discussion that maybe the birthing parent, which is traditionally the mom, maybe that is not the default parent because they get the parental leave, whereas, the traditional dads will take like 4 days. And also for families of all different flavors, adoptive families and other things, that is the next step in terms of wanting to raise awareness and protections for those groups as they expand their families as well.
Okay, last question, and then we're going to close it. Do PDs of residencies with large service requirements like inpatient or call coverage have been shown to have different maternity leave policies? I know GME positions are hospital funded, so I wonder about potential biases.
Yes, definitely. And we definitely saw that, especially for community residencies where they don't actually have a separate GME program. This actually is even more rigid than the experience that we have in, at a university-based setting. And it's because, as we know, historically residents are called house staff because they live in the hospital, and because they provide a really important service component to hospitals. And, all of the different ways in which we've changed training have worked to address that, but many of those vestiges still remain, for sure.
All right, thank you again so much. Not to take the thunder from Drs. Agrawal and Caliendo, but thanks. And we look forward to this this series as an annual event. We promise we won't invite you every year.
I always have stuff to say. Y'all know that. Anyhow, all right. Happy summer. Thank you all for joining us. Thanks, Wendy. Thank you, Kimberly. Thank you, Eric. Thank you, Shub. Y'all have a great afternoon.